There we go. Thank you.
Oh, nice. Okay, good. Okay, I did that slide already. Okay, so this is my land acknowledgement. I am located on the unceded territory of Iroquois, Mi'kmaq, and Passamaquoddy peoples. And Fredericton lies along the beautiful Willistook River, the beautiful, bountiful Willistook River. These are photos taken by my dad that I share. It's so pretty living here. Okay, so abortion. Canada is truly unique in the world, the only jurisdiction in which abortion is completely decriminalized, no limitations on gestational duration in law, no federal stipulations about parental consent, no waiting periods, nothing like that. And it's been that way since 1988 from the Regina versus Morgentaler Supreme Court decision. However, so that's wonderful. Sounds great. However, that's the law. The practicality of the situation was, for all of these years, only physicians could provide abortion. 96% of abortion was procedural, and we now use that language, procedural, instead of surgical, because surgical makes you think there's cutting and there isn't cutting. And as a result of it being all procedural, it was located in predominantly abortion clinics and some hospitals in major urban centers quite close to the US border. Now, the reason for that was because we hadn't had medication abortion approved yet. So I'll get to that in a second. But we were even sending people to the US at later gestational durations because we didn't have the capacity to deal with it in Canada. And also, it was very common to require a referral from primary care before you could get to abortion. So you'd, call up your family practitioner, wait 4 weeks to get into them, get there for them to only say to you, oh, I don't know how to help you. And now you've wasted all this time. So lots of very obvious barriers to accessing care. Then mifepristone came along. So mifepristone was first approved in France in 1988. It's the only medication really that is approved exclusively for abortion. There are other medications that have abortifacient properties, but this is the abortion medication, and we use it in combination with misoprostol. So the mifepristone stops the pregnancy, and the misoprostol causes cramping to expel the contents of the uterus. So when you get the package in Canada, it's called mifegamiso, and it's a white package, and inside the package is your green mifepristone and your orange misoprostol. And that's the color of the packaging, not the color of the pills. They're all white. Okay, so they've had it in France since 1988. Why did we only get Health Canada approval in 2015? Kind of complicated. The best way to explain it is that Canada is truly quite a small market. We're a very small market. We're a very big country. Mifepristone is not a high-use medication, right? It's not like a birth control pill that you take every single day. So it wasn't seen as terribly lucrative for the company to invest the cost to have it approved by Health Canada. But eventually, with lots of pushing and prodding, it did happen. And then by 2017, it was widely available. One of the things that was recognized right out the gates was that we don't have prescription drugs that you get at the community pharmacy under Medicare. And we should have this for sure, because what it's doing effectively is replacing quite an expensive hospital-based physician-provided service. And those things are under Medicare. So quite quickly, we got governments to agree that, yes, we should publicly fund this. And New Brunswick actually was the first province to do that. When mifepristone was first implemented, there were quite a few regulatory restrictions in place, and those were basically borrowed from the Australian model. So things like you had to watch the patient take the first pill. You had to take special training and be certified. You had to register with the manufacturer. You had to dispense the medication yourself as a physician. Only physicians could do it, et cetera, et cetera, et cetera. And anyway, the team that I'm with, the contraception and abortion research team out of UBC Faculty of Medicine, not me, but other people on the team were conducting research at the time and in very close contact with Health Canada, so that integrated knowledge translation process in research. And they were able to tell Health Canada, listen, people are saying that this is not going to make a dent in access because you're basically making it impossible for anyone new to become an abortion provider. The only people who are going to go through all this rigmarole are people who are already doing abortion work. And so, and also none of this is evidence-based. And so Health Canada, one by one, got rid of all these regulatory barriers. And mifepristone is now completely deregulated and like any other medication. So while it's lovely to take special training, you do not have to take special training to become a prescriber. And nurse practitioners can prescribe. So right now, what we have, again, very unique in the entire world, we have the situation where every primary care provider could, in theory, be an abortion provider. The prescribers in family practice, so nurse practitioners or GPs, write the prescription. The patient takes it to the community pharmacy, the pharmacist fills it, and then they go home and have their abortion induced at home. This has totally transformed the abortion landscape in Canada. It has so many implications. I'll just touch on a couple. This is only supposed to be a little 10-minute glimpse. So the most obvious is provider safety. If this is just one thing you are doing, it is very inconspicuous. And indeed, it is just one thing. I'm sure I have another slide that talks about it, but most new people who are adopting medication abortion, they're only doing like less than 10 a year. It's just one thing they're doing as part of their primary care practice. You know, prescription for amoxicillin, referral to ortho, script for mifepristone. It's very private for the patient, and it's in the privacy of their own home. There are a lot of like white coat anxiety things that you can avoid by being able to have this experience at your home. Some patients find it feels more natural, a lot of more convenient, things like that. But the biggest thing is it has normalized abortion. This is normal. It's no different in terms of a process than any other prescription that you would get. So that's such an important piece, the destigmatizing, normalizing abortion. And I think that that is the most compelling thing that nurses can be involved in. We're this enormous workforce in this country. And by talking about abortion and being involved in abortion work, we make abortion normal. So our team, the Contraception and Abortion Research Team, did a bunch of research to look at, okay, what does the environment look like after the implementation of mifepristone in 2017? And what we have found is medication abortion. Obviously, there were studies all over the world that showed this, but here in Canada, medication abortion is also very, very, very safe. So there's no significant change in the rate of adverse events or continued pregnancies when we start seeing more and more adoption of medication abortion in lieu of procedural abortion. And people are adopting it en masse. So back in 2016, right before implementation, like I said, we were about 96% procedural, and again, located in about 100 facilities across the country that were doing procedural abortion, roughly. By the next time we checked the numbers, published in 2021, it's down to 63%. Okay, so the other 37% is medication. We're already in 2024, and I feel like I can guarantee that we're at least at 50-50 now. That said, the abortion rate itself did not change. Overall, the numbers are pretty stable. The rate of second trimester abortion has declined. And that, again, that makes perfect sense. If people are getting access to it quicker because it's in primary care, then you're going to have fewer people delayed into the second trimester. And that, of course, abortion is very safe, but it's safer earlier. So we want our patients, for lots of reasons, to be getting that care in an expedited manner. This is the big thing where nurse practitioners are just super shining. The number of providers has increased so much since the introduction of mifepristone. So right before implementation, we were actually seeing the numbers of providers fall. In part, that's because actually the demand for abortion had fallen a little bit, improved sex ed, improved access to contraception. But also, it wasn't being taught very well in health professional schools, et cetera, et cetera. So we were seeing it go like this. Then MIFI is introduced and whoosh, it shoots up fourfold increase in the number of abortion providers in Canada. That is just wild. But what's even more impressive is that in rural Canada, that number increased 20-fold. So we are directly just attacking that geographic barrier that we were facing prior to this. Like I said earlier, most new providers, 80%, are just doing a couple. It's just something they do. It's part of primary care. Abortion is normal. Abortion is part of this reproductive life cycle. And then, curiously, we've seen that procedural abortion providers' numbers have increased. And we don't really have a reason for that, but we think as abortion care providers that it's because the work is extremely fulfilling. And so people were starting to do this work through medication abortion pathway, found, wow, I'm really making people's lives improved, and they're able to fulfill their dreams and escape violent relationships and finish school. And this feels really good to do. And I'm going to improve my skills so I can do more. That's our theory, but we don't have proof. Okay, COVID. In funny ways, COVID was good for abortion access, dare I say. One thing that happened was governments in Canada very strongly affirmed abortion was essential healthcare. At the time, I was working at the Rose Clinic, Reproductive Options and Services Clinic in Halifax, Nova Scotia. And out of the blue, Nova Scotia Health makes this huge tweet storm about how essential we are, and they're not going to close one day of services. And don't worry, anybody. And they had never talked about us ever. So this was this strange thanks, guys, kind of thing that we were recognized as something that cannot wait. And yes, you go in full of COVID. Come in, we'll gown up, and we will take care of you. The other thing that happened was general normalization of telemedicine across the country. We all know that happened. And so for medication abortion, this meant you don't have to see anybody. There's no appointments. If you meet certain clinical criteria, and there's an algorithm, you don't need blood work, you don't need ultrasound, you just talk to a prescriber on the phone and they fax your script in, and that's it. Remarkable change for patients. Absolutely astonishing. So I've included the link to the SOGC clinical practice guidelines for what we call no touch or low touch abortion, where you're not necessarily doing that blood work, that beta HCG, or the ultrasound. And in general, access has just improved in remarkable ways. Couple of highlights. In 2015, New Brunswick did away with any referrals. So New Brunswick was this old-fashioned place where you had to have 2 physicians approve that your patient needed an abortion, basically because she was mentally unwell, that you had to have some clinical reason. Anyway, that was done with in 2015, over. 2017, PEI opens a full spectrum, absolutely gorgeous abortion clinic after not having services for 35 years. 2018, Nova Scotia launches a 1-800 number anywhere in the province you can call and self-refer. At this point in time, every single province has a self-referral pathway. You might find that you need a referral if it's for a later gestational duration, when you're needing more specialized care. So here are a couple numbers: the centralized number in BC, the centralized number in Nova Scotia, the website in New Brunswick, that our New Brunswick Abortion Care Network, we're a group of independent providers, put together. So that's some resources for you. And I'm able to take questions. That was just like the most tip of the iceberg overview, but hopefully